Today I'm here to present on a project we recently completed at the Central Coast Local Health District. It's evaluating patterns of care in the Aboriginal population accessing our cancer services. The project encompassed 3 objectives. First was to enhance culturally appropriate coordinated care for the Indigenous cancer patients, to better understand the service utilisation patterns of Indigenous cancer patients, and then strengthen the skills and knowledge of Aboriginal health workers, so we could contribute overall to a more robust partnership between cancer services and Aboriginal health services within the district. Central Coast has a population of roughly 327,000, with Indigenous representation at 3.8%, which is above the New South Wales average of 2.9%. Funding through a Cancer Institute Innovations grant provided us an opportunity for cancer services and the Aboriginal health services within the LHD to evaluate and improve cancer care for the Indigenous population. So first we did a profile of cancer patients within the service who identified as Indigenous. We examined the number of patients who had an electronically documented encounter within cancer services for the calendar year 2016. This was regardless of year of diagnosis of cancer. Individual patient electronic medical records were reviewed through Charm Oncology, ARIA Radiation Oncology and Cerner Power Chart. We recorded tumour stream, year of diagnosis, comorbidities and history of tobacco use. Records were also reviewed for engagement with palliative care, psycho-oncology, social work, community cancer care and Aboriginal health services. The limitations of our data collection included a variation in the documentation patterns between practitioners and disciplines, and an inability to review all paper records. We would have liked to have used a comparator group to ascertain differences between the Indigenous and non-Indigenous cancer patients. However, this was beyond the scope of the project. So there's our results. There were 83 patients who identified as Aboriginal and Torres Strait Islander or Torres Strait Islanders. In terms of comorbidities, we had cardiac comorbidities were most prevalent at 24%, followed by diabetes at 16%. And most noticeably, the history of current or previous smoking was documented in 69% of cases. The majority of this information was often pulled from oncology first consultation notes and paper notes, so they were fairly lengthy. We looked at the patterns of utilisation throughout the service, and these results demonstrated a high uptake of the Cancer Nurse Coordinator service. However, there was a low engagement with Aboriginal health. Our Cancer Nurse Coordinators cover all tumour streams except melanoma, and we attributed the low engagement with Aboriginal health services to multiple factors. There's no formal referral processes between Aboriginal health service staff and cancer services in place. In addition, it's a predominantly outpatient model of cancer care, which complicates access to Indigenous cancer patients for roles such as the Aboriginal Health Liaison Officer. We then went and surveyed the Aboriginal Health Service staff to evaluate gaps in service for Indigenous patients and assess the educational needs and interests of the Aboriginal Health Service staff. Our response rate was 46%. The results indicated, Results from the survey indicated knowledge gaps in the social support services available to cancer patients, particularly transport, and identified palliative care needs of Indigenous cancer patients as vastly under-resourced. So putting this data together and the information from the Aboriginal Health Service staff, the project was able to convene varying disciplines to provide Aboriginal Health Service staff with information and practical experience in the care of oncology patients. This included Aboriginal Health Service staff attending Introduction to Oncology Nursing one-day programs and supernumerary time in radiation oncology, palliative care and the chemotherapy day unit. Indigenous-specific cancer resources and literature were available from an array of institutions and sources. However, we needed a localised solution for our Aboriginal Health Service staff to easily access accurate and culturally appropriate localised information. Women's cancer, particularly ovarian and cervical, was identified as a key area of need due to the complex nature of the treatment, which often required travelling to receive treatment outside of the Central Coast. So our brachytherapy services, we have none on the coast, so cervical cancer patients needing brachytherapy do have to travel. And it can be quite a stressful period, particularly for the Indigenous population. Literature was developed in collaboration with Women's Health and the Radiation Oncology Surgical CNC. So we raised awareness with cancer services staff of the services offered by the Aboriginal Health Service through formal and informal communications. A lot of it was reinforcing identifying at first contact, inquiring about Aboriginality and frontline staff, things as basic as that. Then we moved on to develop Indigenous specific cancer resources on the intranet. So the internal hospital intranet, in collaboration with IM&T. We established an intranet site within the existing Aboriginal Health Service intranet that collated all the information, was culturally appropriate and evidence-based and localised, that the health workers could use to look after their patients with cancer. It's anticipated we'll sustain this beyond the life of the project and help in future care. The local health district Aboriginal Health Service chronic care team had been informally encompassing cancer inpatients in their daily census and adding this to their workload. Work was completed so they could have routine reporting on Indigenous patients who were both inpatients and outpatients, and this will help us move forward in establishing better patterns of care for these patients. We took some work to the community. We did community yarning sessions. Each session had a particular focus within cancer. So these mornings presented an opportunity to consult with the Indigenous community on all aspects of cancer care and prevention, and also on their concerns. We commenced with a focus on women's health, breast and cervical screening, cancer prevention and early detection. Our locally developed literature was reviewed at these mornings and the consumer feedback was taken on board. We also, at these mornings, we have a health centre next to the cancer centre, an Indigenous health centre, which has recently opened a couple of clinical rooms. So after the screening morning, there was also the opportunity for any Indigenous attendees to go and have screening done privately and in a culturally safe environment. So we do plan to keep these mornings going. It was an excellent opportunity to work with the community. Also, our further yarning sessions we're going to plan will engage other Indigenous health services outside the LHD. We have 2 or 3 other services and we're not meeting the needs of the patients that they serve as well, so they're in our sites. What does the future hold? So in late 2017, the LHD commissioned Aboriginal Health Review was released. It was fortuitous that that happened at the same time. Aboriginal health was recognised as the shared responsibility of all services within the LHD, and it was noted that there's gaps in specialised care and management of Indigenous patients with cancer. Future investment in an Indigenous health worker is tabled, and we hope that the work that we've done to date will assist in putting that in place. Thank you.
Thanks, Larissa. We'll take questions. We have a couple of roving mics going around. Who's first? Okay, I have a question. There are multiple parts of the equity discussion, and I guess one of them is a health system that supports equitable access to it. One of the points I noticed was when you talked about doing your data discovery, the laborious process of going through paper notes. How much value do you think there is in investing in, I guess, more prospective ways of collecting these data so that we can actually take action based on them? So collecting that information as either part of longer term surveys or building around the EHR, or what are your thoughts on that?
I think building within the EHR is important. We're at the start of our OMIS implementation, so these are things moving forward that we'll be looking to incorporate into the OMIS, and also just the very basics of awareness of Indigenous status and having that routinely reviewed. So if they're not coming out with it, say at their first consult at the administration desk, getting the cancer nurse coordinator to review that further down the line as routine questions, they may feel more comfortable identifying further into their treatment. So trying to get that culture of just consistently asking the question.
I remember when we started, well, not when we started, but when there were real pushes to get people to ask the question and make sure they were checking that status. You know, we've come quite away from there, but we're still not
There
quite
yet.
capturing it, are we?
No.
Thanks, Larissa, that was great. I was just wondering about the sort of routine referral, a systematic referral to Aboriginal Health Services when an Aboriginal person does identify, if they would like that. How easy or difficult was that to get up and running?
It was quite difficult. It was complicated, and I'm sure this is a familiar story. We probably have 4 different electronic systems, so there's no one overarching way to do it electronically. It really came down to person-to-person care, the Aboriginal health staff knowing us, knowing the cancer coordinators, and embedding that culture of trying to refer. We did develop some cards as well, and we publicised it as much as we could, but we need to embed it further.
We will please thank Larissa again.
Thank you.